In this section, we're going to start talking about weight management. Despite long-term recognition of obesity as a problem, new emphasis on ending this epidemic has taken center stage in policy, government, and professional and clinical domains. Never so much has been written about this problem, or so much attention has been paid to it. With 2/3 of Americans classified as overweight or obese, there is a renewed attention on weight loss. Obese children who were formerly ignored are now at the forefront of clinical attention. Overall, the use of medications in treating obesity has not proved to be effective as a long-term solution for most individuals. However, initial weight loss may encourage the patient to make other changes regarding exercise or eating behavior that will lead to more lasting weight loss. Medications that help in managing obesity either act centrally or impair dietary intake, or act peripherally to impair dietary absorption or increase energy expenditure. Obesity in excess of body fat Obesity is an excess of body fat relative to lean body mass. Overweight is defined as a body mass index, or BMI, of 25 to 29.9 kilograms per meter squared. Obesity is defined as BMI of 30 kilograms meter squared or greater, according to clinical guidelines on the identification, evaluation, and treatment of overweight and obesity in adults. This was published by the National Heart, Lung, and Blood Institute. These guidelines provide information underlying the diagnosis and management of obesity and should be consulted by all clinicians. The relationship between physical activity, diet, genetics, and other factors make weight reduction a complex psychological process. Even for those individuals trying to lose weight, hunger-inducing hormones such as ghrelin remained at an altered level 1 year after patients lose weight due to dieting. This is why psychologic understanding and approaches are so important. Simply refraining from one's relationship with food is essential. The medical world attempts to explain obesity on the complex physiologic aspects and ignores the psychological aspects of care. These biological changes may explain why maintaining weight is so difficult. The BMI is a number that is derived by dividing the weight in kilograms by the height in meters squared. The easiest way for most individuals to do the calculation is to multiply 704.5 by the patient's weight in pounds. Divide that number by the patient's height in inches multiplied by itself. There are conversion charts that are easily available. Although several classifications and definitions for degrees of obesity are accepted, the most widely accepted classifications are those from the World Health Organization based on BMI. The World Health Organization designates grade 1 overweight of a BMI 25 to 29.9. Grade 2 overweight, often called obesity, is a BMI of 30 to 39.9, and grade 3 overweight, commonly called severe or morbid obesity, is a BMI greater than or equal to 40 kilograms per meter squared. So drug overview: anorexiants, mixed neurotransmitter reuptake inhibitors, and symptomatic drugs are used. Lipase inhibitors, and these medications are indicated for obesity. Phentermine is for short-term use only. For anorexiants, these are indicated. These are indirect-acting sympathomimetic amines. They are thought to provide direct stimulant effect on the salivatory center in the hypothalamus. Phentermine is a class 4 controlled substance that acts by modulating central norepinephrine and dopamine receptors through the promotion of catecholamine release. Orlistat works through a completely different mechanism. Orlistat blocks approximately 30% of fat absorption within the GI tract. It acts locally and is minimally absorbed. The GI tract enzyme lipase together with cholipase breaks down fat molecules before they can be absorbed. Orlistat interferes with lipase and works in the jejunum to inhibit pancreatic lipase. So for treatment principles, non-pharmacological treatment, no single treatment modality is independently effective in the management of obesity. Intervention is unlikely to be effective if it is not tempered with strategies designed to enable the patient to make permanent lifestyle changes. It is a common misconception that drug therapy alone will control this problem. Any successful weight loss program is based on a screening phase, a definitive weight loss program, and maintenance phase that may conceivably last for the rest of the patient's life, but that must last at least 2 years after completion of weight loss program. The weight loss regimen includes a reduction in caloric intake and an increase in physical exercise. With both of these, weight loss is generally transient. Medications may be helpful in both foundational areas in suppressing appetite and helping in keep energy levels high so the patient feels like exercising. For diet, Americans have found to eat more food and eat more frequently. Larger portions and more processed high-calorie foods contribute to high-calorie intake on a regular basis. Obesity and often diabetes mellitus are lifestyle diseases. Lowering of caloric intake every day will result in a reasonable, slow, steady weight loss. Several valid methods may be used to arrive at the proper dietary prescription for an individual, but it is not effective to lose quickly without maintaining on a program. Total daily allotment of calories is based on the requirements of the patient and depends on his or her nutritional status when the diet is initiated and on the estimate of daily activity. During their peak growth period, active adolescent boys need 3,100 to 3,600 calories per day, and adolescent girls need 2,400 to 2,700 calories per day. Children generally require 1,000 calories per day plus an additional 100 calories for every year of age. Accordingly, a 10-year-old child should receive approximately 2,000 calories daily. A general rule of thumb is that it takes approximately 10 calories to support each pound of body weight. For example, a 150-pound woman is probably eating 1,500 calories. To lose weight, the patient must decrease intake to below the level needed to maintain that weight. The patient must decrease daily intake by 500 calories for each pound he or she wishes to lose weekly. Weight loss of about 1 to 2 pounds per week commonly will occur for up to 6 months. After 6 months, the rate of weight loss will often plateau. This occurs because the patient has lower energy expenditure at the lower weight. Once a patient has plateaued, evaluate whether he or she needs to lose more weight. If so, reevaluation of diet and exercise is required. The patient must further decrease calories and/or increase physical activity to achieve this. 3 major types of diets are used: balanced, low-fat, and low-carbohydrate. Much controversy has arisen about diets for obesity. Although patients may lose more weight initially on a low-carbohydrate diet, the weight loss after 1 year is about equal for low-carbohydrate and low-fat diets. But the low-carbohydrate or Mediterranean diets have more favorable effects on lipids or glycemic control. Thus, whatever the diet, the patient should be encouraged to make reasonable eating changes that they can live with for years and avoid extremes, and to have balanced nutrition to eat to what they eat. Rapid weight loss is not advisable. A study has shown that regarding regaining weight almost always follows rapid weight reduction. Also, the risk of gallstones and electrolyte abnormalities are increased when weight loss is excessive. Once the patient has reached a particular weight loss goal, the goal is changed to weight maintenance at the lower weight. It is important to continue to monitor these patients to help them stay at this lower weight. In 2008, a new system for scoring the nutritional value of some foods became available in grocery stores. This has helped to standardize the way to make healthier food choices. For physical activity, an increase in physical activity is a second essential component of weight reduction. Exercise leads to increased expenditure of energy, inhibits food intake, and reduces overall cardiovascular risk factors. Efforts to lose weight by exercise alone without calorie reduction usually produces approximately a 2 to 3% weight decrease. The U.S. Census data showed American adults on an average spend 2 hours each week on sports and fitness activities, about half as much as recommended. Walking was the most popular activity, while basketball was the most popular sport. Vigorous exercise has been shown to burn calories up to 14 hours after a workout. And this should be explained to the patient. Behavior changes in behavior is necessary to achieve long-term weight loss. They must change basic eating and activity patterns. Specific strategies include keeping a food diary, maintaining stress, controlling stimuli, avoiding situations that precipitate overeating, solving problems, and providing contingencies, cognitive restructuring, setting realistic goals, and social support. Surgery has been a choice for the extremely obese individuals with comorbid problems. Surgery is used after pharmacologic therapy has proved ineffective. Several surgical procedures are currently being used and are really much more common. These include bariatric surgery, vertical banded gastroplasty, gastric banding, and gastric bypass. Patients who require surgical intervention should find a surgical specialist who has experience with extremely obese patients and need to continue diet and exercise even after surgery. For patients who undergo gastric surgery, clinician may have to deal with surgically created malabsorption or physical restrictions. Regurgitation is a significant problem with restrictive surgery in many patients. These people have a high level of intolerance to food. They will need to make major changes in their diet. Malabsorption syndromes may lead to micronutrient or macronutrient deficiencies, anemia, protein malnutrition, dumping syndrome, and many other issues. Gastric leaking may also be a problem at the site of the anastomosis. This leads to peritonitis. Patients need medical and psychologic monitoring after these surgeries. For pharmacological treatment, critical decisions that must be made relate to whether it's appropriate to use pharmacological therapy, and if so, whether the patient has any conditions that contraindicate its use. Clinical trials have shown that use of these drugs in combination with a sensible diet results in approximately a 6 to 12 pound mean weight loss. Weight loss drugs should be used only for patients who are at increased medical risk because of their weight and should not be used for cosmetic weight loss. Guidelines state that these drugs may be useful for a patient with a BMI of 30 or greater with no obesity-related risk factors or diseases, or for a patient with a BMI of 27 or greater with obesity-related risk factors or diseases. Medications work by helping the patient stay on a diet and exercise plan. A drug will not cause weight loss if the patient continues to eat at the same level. Most of the weight loss will occur during the first 6 months of treatment with the drug. If the patient does not respond within the first month of therapy, the likelihood of response is very low. Phentermine is used as a short-term adjunct in weight reduction. It should not be used for longer than a few weeks. It may be tried if a sibutramine is ineffective. However, significant serious risk factors are associated with their use. Xenical, or orlistat, acts to increase fecal fat excretion. The extent of drug activity may be determined by measuring the amount of fat in the stool. The maximum amount of fat excretion is about 25 to 30%. If 100 grams of fat is consumed in a day, 30 grams will end up in the stool. Once the medication is stopped, fecal fat excretion goes back down to normal. Xenical has been shown to be about as effective or perhaps a little less effective than the symptomimetics. In short-term study, an approximately reduction of initial weight of 10% was reported. In long-term studies, most of the weight loss occurred during the first months and was maintained for up to 2 years. This medication is associated with irritating GI side effects, such as soft liquid stools and oil in the stool. Some people have had oily stool spotting, necessitating the use of mini pads. These symptoms appear to be dose-dependent. Long-term use may be associated with the development of vitamin defects. Levels of vitamin D and beta-carotene were decreased by 20 to 24%, but remained within normal range. Fat-soluble vitamin supplementation may be required. Patients taking both orlistat and levothyroxine should be monitored for changes in thyroid function. Orlistat may interfere with the absorption of levothyroxine from the gastrointestinal tract. Administration of levothyroxine and orlistat must be given 4 hours apart. Also, patients may ask about herbal and over-the-counter products that are advertised to help with weight loss. There's much information about fat substitutes. Patients might ask about medications derived from the exoskeletons of shrimp and lobster. These products absorb fat and have been used for the cleanup of oil spills. These fat absorbers are available in some health food stores. No data can be found in the professional literature regarding the use of these products. Over-the-counter products used for weight loss have often contained ephedrine, which is available in herbal form. Ephedrine can be very dangerous, causing strokes, headaches, tachycardia, hypertension, and catecholamine-like symptoms such as restlessness, dry mouth, insomnia, fatigue, and other central nervous system effects. Ephedrine use should be discouraged and advised. Adverse effects from ephedrine have caused the FDA to remove this product from most preparations. A variety of other medications have been used off-label to help with weight loss. The antidepressant Wellbutrin plus anti-epileptic agent zonisamide has been found to be more effective than placebo. Wellbutrin started at a dose of 100 milligrams per day, which is increased to 200 milligrams per day after 2 weeks. Has been effective. Zonisamide is started at 100 milligrams per day and gradual titration up to 400 milligrams per day by week 4. Selective serotonin reuptake inhibitors have been used off-label because they often produce anorexia. SSRIs are often helpful in the short term in weight reduction, but long-term use is associated with weight gain. Osmia is a controlled release formulation taken once a day that combines low doses of 2 older generic drugs. It combines low-dose topiramate, generic drug also known as Topamax, used to treat seizures and migraines, and phentermine, a mild stimulant approved by the FDA for short-term weight loss. Phentermine suppresses the appetite soon after the pill is taken, and topramate, which kicks in later in the day, creates a sense of feeling full. Patients also have shown improvements in blood pressure, cholesterol, and triglyceride levels, and inflammatory markers. And for those with diabetes or pre-diabetes, blood sugar levels improved. There's also many other new drugs coming out. For example, Bevega is another new drug that acts by blocking appetite signals to the brain to help people feel full after eating smaller amounts of food. Again, all of these drugs need a program with them because patients need to diet as well as exercise while taking these medications. Treatment principles, treatment goals in working with the overweight or obese individuals are to prevent further weight gain, reduce body weight, and maintain a lower body weight over a long-term period. An initial goal is to reduce body weight by about 10% from baseline. A reasonable time frame for this loss is about 6 months. How do we monitor these patients? Monitor the patient's progress at least monthly. The patient may benefit from weekly weight assessments during the first 3 months and then monthly after. For patients who seem compliant but do not lose weight, look for other medications that they are taking to see if they might be contributing to weight gain. Insulin, sulfurias, and some thiazide diuretics, loop diuretics, calcium channel blockers, beta blockers, and alpha-adrenergic blockers. Medications that block histamine H1 or active H3 receptors increase appetite. Corticosteroids, sex steroids, and many anti-epileptics, psychotherapeutic agents, atypical antipsychotics, antidepressants, and ADHD medications may also contribute to weight gain. For patients' variables, geriatrics, orlistat, monitor nutritional status for vitamin E, D, or B deficiency. For pediatric patients, phentermine or orlistat safety and efficacy has not been established. Do not use for children less than 16 years of age. For pregnancy and lactation, orlistat is category B. It's not recommended. Category C, phentermine, is also not recommended. For patient education, phentermine, the drug may cause insomnia. Avoid taking this medication late in the day. Avoid alcohol or other CNS active drugs and anorectic agents. Notify the provider if they experience palpitations, nervousness, or dizziness, and the drug may cause dry mouth and constipation. It also may produce dizziness or blurred vision, which may interfere with driving or performing other tasks that require alertness. This drug should be taken on an empty stomach. Orlistat should be taken with a meal. Patients should take a multivitamin at a different time from when the medication is taken, and remind them that this may cause leakage of stool. Now we're going to move on to vitamins and minerals. The integrity of the health of the body are maintained through nutrients. Most commonly, these nutrients come from natural sources. With poor diet or during times of stress or illness, supplementation may be required. Vitamins and minerals then may become more important components of the therapeutic regimen. Additionally, new research findings confirm that the role of some of these formulations play in improving or preventing some chronic diseases. Many non-prescription vitamin preparations and many other individual vitamins and minerals sold over the counter patients may be on. Prescriptions may be required for costs to be covered by insurance and by Medicare. Vitamins and minerals are by definition essential for human life, and their role in basic metabolism has been well researched. However, extensive new research documents their role in health promotion and disease prevention. This is a rapidly developing field, and consumers are paying attention to this. You'll find many patients are on a multiple regimen of diets and vitamins. There are general multivitamins. You have multivitamins with minerals, multivitamins with fluoride, parental multivitamins, prenatal vitamins, which can be obtained over the counter, as well as prenatal prescription tablets. Although most people get enough vitamins to avoid classic deficiency diseases, research suggests that relatively few get enough of the 5 key vitamins. These include folic acid, vitamins B6, B12, D, and E. A standard store brand RDA level multivitamin can supply enough of these vitamins for less than $40 a year. It may be difficult to find high quality information about vitamins, minerals, and specific products because of the influence of the food industry. For other multivitamin formulations and products, there's the anti-folic acid antagonists, the antioxidant combinations, geriatric vitamin formulations, pediatric vitamin formulations, pediatric vitamins with fluoride, iron combinations, iron with vitamin B12, and extrinsic factor. So what are vitamins? Vitamins are organic materials essential for human survival that must be ingested on a regular basis because they are not synthesized by the body. Some are available in their active form, others are ingested as precursors or provitamins that are then converted. 2 vitamins, vitamin K and biotin, are not ingested at all but are synthesized by bacteria inside the intestinal tract. 13 essential vitamins have been identified, and more information about essential nutrients is being discovered every year. Only tiny quantities of vitamins are required on a daily basis, but chronic deprivation of even 1 vitamin will cause disease and death can occur. The inverse is also true. Some vitamins ingested in large quantities will cause illness and death as well. An adequate diet is one that includes an appropriate amount of each vitamin on a daily basis and does not include excessive amounts of any of them. This is a list of the 13 most common vitamins that are necessary. The body needs only a small amount of vitamins. That's why these are often referred as micronutrients, because the body uses them without breaking them down, as happens to carbohydrates and other macronutrients. So far, 13 compounds have been classified. They're classified into 2 types: fat-soluble, which will dissolve in oil, and water-soluble, which will dissolve in water. Vitamins A, D, E, and K, the 4 fat-soluble vitamins, tend to accumulate in the body. Vitamin C and the 8 B vitamins, biotin, folate, niacin, pantothenic acid, riboflavin, thiamine, vitamin B6, and vitamin B12 dissolve in water, so excess amounts are excreted. Vitamins primarily serve regulatory functions and assist in the production of energy. They are not used in the body for structural purposes and cannot be used as an energy source. Vitamins are essential, but differ markedly in the absorption and potential for toxicity. For the fat-soluble vitamins, which includes the A, D, E, and K, these are found primarily in various plant and animal oil and fats. Because these vitamins are stored in our body fat, daily ingestion is not required, but adequate body levels must be maintained over a long term. When ingested, these vitamins are transported through the body by the bloodstream For vitamins to remain dissolved in the blood, unique carrier proteins are required for each. Some people with particular metabolic and genetic diseases are unable to synthesize carrier proteins and can have extreme vitamin deficiency states despite adequate vitamin intake. Fat-soluble vitamins have common properties: their ability to be stored, their mode of transport, and the severity of deficiency syndromes in young children, but each vitamin is unique in its function and its physiologic effects of deficiency and toxicity. Development of fat-soluble vitamin deficiency can be gradual and the symptoms subtle, but toxicities can present subtly and can be devastating in their effect. Overdosage is more of a problem with fat-soluble vitamins than with water-soluble vitamins because of their ability to be stored and accumulated. Water-soluble vitamins include the B vitamins, B1, B2, B3, B6, B12, folacin, biotin, and pantothenic acid, and vitamin C. With the exception of B12, these vitamins are rapidly excreted from the body because the body has no way to store them. These vitamins must be ingested on a regular basis or deficiency symptoms will quickly appear. They are not particularly toxic, however, because high levels rarely develop since they're excreted. These products and not stored. These products are readily available but are destroyed by heat. Because they are water soluble, the vitamins may leach out into water used for cooking and may be discarded if the consumer is not aware of how to properly store and cook them. Overdosage may occur when large quantities are taken chronically and exceed the body's ability to excrete them. The definition of a healthy daily intake of B vitamins is not set in stone and is likely to change over the next few years. Because only a fraction of U.S. adults generally get the recommended daily intake of B vitamins through diet, use of a multivitamin supplement is becoming increasingly important. For the minerals, these are inorganic substances present in the body that work in combination with enzymes, hormones, and vitamins. Most human minerals are found in the skeleton and make up about 4% of the total body weight. Calcium and phosphorus are by far the predominant minerals in the body. Minerals similar to vitamins are essential for body function but are present in much smaller amounts. Both acute and chronic mineral deficiency as well as toxicities can occur because even though the daily intake may vary enormously, the average adult will consistently excrete several grams of minerals every day. Minerals are classified as major or trace. Major minerals are the calcium, phosphorus, magnesium, potassium, sodium, and chloride must account for at least 0.01% of body weight. Trace minerals, arsenic, chromium, cobalt, copper, fluoride, iodine, iron, manganese, molybdenum, nickel, selenium, silicon, tin, menadione, and zinc fall into the 0.01% but are still measurable and have a metabolic impact, although the exact biological significance of some of these trace minerals remains a mystery. The label applied to a particular mineral, major or trace, does not imply significance. Excess or deficiency of any of these minerals can be devastating. Minerals are found in a variety of states as free ions or bound to many different substances, such as iron to hemoglobin or cobalt to vitamin B12. This variety allows minerals to perform many different biological roles within the body. So how do we monitor patients for vitamin deficiencies? Numerous tools are now available that provide non-invasive monitoring of dietary patterns or serve as computerized nutritional assessment tools. These are available online. There's a resource for clinicians as well as laypersons. Many of the commercial weight loss programs have websites at which individuals can complete a daily food and exercise log and receive feedback about dietary intake. Blood studies to determine nutrient levels generally are not indicated. If a person presents with a particular set of physical symptoms that seem to be related to nutrient deficiencies or toxicities, blood and hair studies by specialists may provide some diagnoses. For patient variables, daily requirements of vitamins and minerals vary from person to person with age, sex, physiological state, for example, pregnancy, and physical activity. The development of a complete comprehensive list is impossible. So there was developed a list of RDAs, which was first published in 1943 and is updated every few years. This list is not intended to be comprehensive, but attempts to define what amounts of each vitamin and mineral would be appropriate to meet the needs of normal, healthy people. For geriatric patients, elderly people may have highly variable nutritional needs depending on their state of health. Metabolic changes have slowed the digestive tract, increased the fat-to-muscle ratio, and decreased liver and renal functions. All of these events have an impact on digestion, absorption, and excretion of vitamins and minerals. Use of medication also can have significant impact on absorption and utilization of nutrients. Dietary deficiencies in the elderly can occur for many reasons. For example, because older persons may not eat sufficient food, may not eat the correct foods, or may not eat adequate variety of foods. Vitamin B12 deficiency may result from decreased acidity of the stomach. The signs of vitamin deficiency may be subtle, but always should be considered. For example, a thiamine deficiency associated with alcohol abuse can cause Wernicke's encephalopathy or organic amnesic syndrome. Folic acid deficiency is associated with dementia, and vitamin B12 deficiency can result in psychologic changes and peripheral neuropathy. Vitamin D deficiency is not uncommon among the elderly, especially in nursing home residents or others who do not get out in the sun. A vitamin D deficiency can contribute to osteoporosis. In pediatrics, RDAs for the various vitamins and minerals vary widely. Age and body weight are significant factors, and careful attention should be paid to children's diets through the growing years. Nutrient deficiency states are always quickly seen and often are more devastating in children than adults. Some deficiencies can have lifelong effects, as well as, for example, vitamin D deficiency causes abnormalities in bone ossification, causing bones to become soft and bend in a disease called rickets. Vitamin D therapy will stop further damage but will not correct many existing bone deformities. As children grow, their need for supplementation changes. Breastfed infants get all of their nutrients they need from their mother. The only supplements these babies may need is fluoride, which is only present in small amounts of breast milk, and an iron supplement after 4 to 6 months of age. Bottle-fed infants receiving infant formula are receiving the RDAs through the formula. Consider the use of iron-fortified formula after age 4 months. As infants start to eat solid foods, however, many children develop strong food preferences, and parents can struggle to maintain a balanced diet. Balance over time is the important point to remember. Not every meal has to include every nutrient. Ensuring balance for the day is sufficient. Caution parents to avoid food conflicts by frequently offering small portions of food from many different sources. Vitamin supplementation is not necessary for a child who is willing to eat from many food groups, but it may be helpful in the child who eats only a small variety of foods. For those pregnant and lactating, in general, most all vitamins and mineral RDAs increase during pregnancy to support the increase in metabolic rate and the demands of the growing fetus. These nutritional needs, with the exception of iron, can be met by most women through diet. Iron requirements during pregnancy are nearly impossible to meet by diet alone, and iron deficiency anemia may result. Folic acid supplements is being recognized increasingly as an essential pregnancy nutrient, and many providers are recommending the use of iron and folic acid supplementation by all pregnant women. One potential problem in pregnancy is vitamin and or mineral toxicity. Nutrients that are particularly harmful to the developing fetus, if provided in excess, include iron, zinc, selenium, and vitamins A, B6, C, and D. This would be 10 or more times the RDA. Although some vitamins taken in excess just pass through the system and are excreted in the urine, other vitamins may be stored in tissues, and toxicity may develop. When megadoses of vitamins such as A and C are constantly taken, the body develops a tolerance for the higher doses. Gender, men's nutritional needs remain relatively stable from late adolescence into old age. With aging, illness, and injury, dietary needs must be reassessed, and supplementation may be considered. Elderly men over 80 years of age are at relative risk for osteoporosis, and adequate calcium intake is essential in elderly men and women. Women's needs vary widely throughout their lifetime. Until adolescence, children's needs are essentially the same, and a gradual increase in RDA is noted for most nutrients. During adolescence, however, women's dietary needs undergo major changes. With the onset of menses, dietary iron needs increase. Many women do not take adequate amounts of dietary iron to compensate for the monthly blood loss. This need decreases with the use of hormonal contraception. Adolescents and young women lower their relative risk of iron deficiency anemia when they use hormonal contraception. It is certainly possible for an individual to provide sufficient iron in their diet, but because many women's diet many women diet to keep their weight down, and men may engage in excessive exercise, and because many individuals do not develop good food habits, many American diets are inadequate, and iron supplementation should be considered. Folic acid supplementation, 400 micrograms, should be taken by all women of reproductive age. A deficiency in this B vitamin has shown to be related to an increase in neural tube defects in the developing fetus. Appropriate calcium intake is a significant problem for women. Chronic calcium deficiency often starts in the young woman and worsens with age. As adolescents begin, many women stop drinking milk. Many women become deficient in calcium just when they need it most for pregnancy, lactation, and menopause. Bone loss accelerates during the first 5 to 10 years after menopause, and if not stopped, can lead to devastating consequences. For patient education, all individuals should be counseled regarding their nutritional needs. Patients should be aware of the needs of growing children, should learn how to manage their children's diets. Young teenagers should be told about the importance of a balanced diet. This is particularly important in youth engaged in vigorous sports or types of dance such as wrestling or ballet, when forced weight loss may be an issue, or when they are attempting to lose or gain weight. Older adolescents should be aware of typical pitfalls, which include decreased calcium intake, increased alcohol and soda consumption, and fad and weight reduction diets. They also should be informed about the hazards of vitamins and minerals toxicities. Pregnant and lactating women, as well as young mothers, require frequent nutritional updates as they progress through the childbearing years. Older women should be encouraged to supplement their diet with calcium and vitamin D to prevent osteoporosis. Older people of both genders should receive periodic reminders of the importance of a balance in diet. Together with their care provider, should consider appropriate nutritional supplementation when illness or injury occurs. There's been a controversy over the antioxidants. The hypothesis that antioxidant vitamins may reduce the relative risk of many degenerative disease is based on a large body of basic and human epidemiologic research. However, this hypothesis is unsupported by randomized placebo-controlled trials. One of the most consistent findings in dietary research is that of those who consume larger quantities of fruits and vegetables have a lower rates of heart disease, stroke, and cancer. Attention has been focused recently on antioxidant content of fruits and vegetables as a possible explanation for their apparent protective effects. Antioxidant vitamins, which include beta-carotene, provitamin A, vitamin E, and vitamin C, are hypothesized to decrease cancer relative risk by preventing tissue damage, by trapping organic free radicals, and by or deactivating excited oxygen molecules, a byproduct of many metabolic functions. These micronutrients may be reduced by smoking and passive smoking. So for the fat-soluble vitamins, we'll start with vitamin A, retinol, beta-carotenes, and carotenoids. Vitamin A was the first vitamin discovered. It was identified in the early 1900s and occurs in 3 forms. The retinols, beta-carotenes, and carotenoids. Retinols are already active and are found in animal sources. The retinols are the most active form of vitamin A. Beta-carotene are provitamin A, which requires conversion to the active form. These are derived from plant sources. The carotenoids exist as a free alcohol or in a fatty acetyl ester form. Because retinol is fat-soluble and stored in the liver, daily intake is non-essential. Retinol is transported through the blood by retinol-binding proteins. It stimulates the production and activity of white blood cells, takes part in remodeling bone, helps maintain the health of endothelial cells, those lining the body's interior surface, and regulates cell growth and division, as well as enhances vision. Deficiency in vitamin A ranks as the 3rd most common nutritional deficiency in the world. It is rare in most industrialized countries. Vitamin A deficiency, which is the most common cause of blindness in children around the world, causes a decrease in visual acuity, especially night vision. Without vitamin A supplementation, the corneal epithelium becomes dry, inflamed, and eventually keratinized, causing permanent scarring. Epithelial tissues throughout the body is affected by a deficiency in vitamin A, which is manifested by carotene deposits. Early in the syndrome, deposits occur around hair follicles, and hardened, pigmented goosebumps appear on the extremities. As the deficiency progresses, a larger portion of the body is involved. The skin peeling and scaling occurs. Internal effects such as GI tract disturbances, oral and vaginal dryness, and keratinization is also seen. Toxicity can occur. Vitamin A, especially retinol, taken in excess, can be hazardous and even life-threatening. Signs of vitamin A toxicity include epithelial lining problems, including involving the GI tract, such as nausea, vomiting, and pain leading to weight loss and anorexia. Mouth problems, such as cracking, drying, scaling, and bleeding lips and mouth corners. And scalp conditions, hair loss, and itching. Other effects include amenorrhea, spleen and liver enlargement, transient hydrocephalus, and bone problems, such as joint pain and stunting of growth. Effects on the developing fetus have been noted in animals, and congenital malformations have been clearly documented. In humans, doses in excess of 31,000 or 36,000 IU have been related to an increase in birth defects and an increase in relative risks of hip fractures. Too much preformed vitamin A interferes with the beneficial actions of vitamin D. The RDA of vitamin A is based on retinol equivalents or micrograms of retinol. 1 retinol equivalent equals 1 microgram of retinol. 1 retinol equivalent of vitamin A equals 3.33 units of retinol, which equals 10 units of beta-carotene. The RDA is 400 to 500 micrograms per day. For infants less than a year, 300 micrograms per day for children 1 to 3 years, 400 micrograms per day 4 to 8 years, 600 micrograms per day for boys and girls 9 to 13, 900 micrograms per day for men, or 3,000 IUs for those 14 to 70 years, and 700 micrograms for women, or 2,333 IUs for 14 to 70 years old. For vitamin D, vitamin D2, vitamin D acts as both a vitamin and a hormone. As a vitamin, it's present in food, and when ingested, it's immediately available for use. As a hormone, it is formed in one organ and has effects on the other. Vitamin D3 is a steroid derivative. After irradiation by UV light, an inactive sterol converts to cholecalciferol. It's converted again within the liver, travels to the kidney, and converted into the active form of vitamin D3. D3 travels to the bone and the gut, where it exerts its effects, which are modified by positive and negative feedback loops. Deficiencies occur it was extremely common before the early 1900s and resulted in rickets and osteomalacia. In both cases, the problem was inadequate bone ossification caused soft, pliable bones. During the early 1900s, it was discovered that lack of sunlight is the cause of rickets, and this has not been found in many areas. Vitamin D deficiency contributes to osteoporosis. Some recommend measuring vitamin D levels in elderly and a relative risk persons and supplementing as needing. Toxicity can occur in large doses because it is stored in fat cells and not readily eliminated. Toxicity is more likely to occur in young children, and the consequences are more serious for them as well. Recommended daily allowances, again, it changes in age, and you can look these up. For vitamin E, some experts consider vitamin E to be one of the most important antioxidants. It protects cell membranes and prevents damages to enzymes associated with them. Natural sources include vegetable oils such as sunflower oil, grains, oats, nuts, and dairy products. Vitamin D might be neuroprotective and with potential use in helping prevent Alzheimer's disease. It may also shut down in a critical enzymatic pathway to make platelets less sticky, thereby helping to prevent clogging of the arteries. However, research is still being done. Deficiency is difficult to diagnose because it can be subtle, can manifest in many body systems or in only one. Vitamin E deficiency has been well documented in animals, but has not been seen in healthy people who eat a variety in their diet. Children are more vulnerable to this deficiency and most present with hematologic symptoms such as severe anemia and hemorrhage. Because vitamin E absorption is dependent on pancreatic secretions and bile, biliary obstruction or pancreatic insufficiency can result in deficiency. Megadoses of vitamin E are better tolerated than doses of many of the other fat-soluble vitamins, and toxicity is rarely seen. Recommended daily allowances does, again, change with age, and you can look these up. For vitamin K, helps to make 6 of the 13 proteins needed for blood clotting. Its role in maintaining the clotting cascade is very important. That people who take anticoagulants such as Coumadin must be careful to keep their vitamin K intake stable. It's also involved in building bone. Low levels of vitamin K circulating have been linked to low bone density, and supplementation leads to improvement in biochemical measures of bone health. Deficiencies is rare because vitamin K is so widely available in both dietary and internal sources. Deficiency can be a problem in newborn infants with sterile intestinal tracts, so synthetic vitamin K is given shortly after birth. Early feeding introduces bacteria into the gut so the newborns can start making their own vitamin K. Medications can interfere with vitamin K metabolism and absorption, and the coumadins all decrease the warfarin and the coumadins all decrease vitamin K effectiveness, usually by competing for biological active receptor sites. For toxicity, it's been rarely seen in vitamin K, despite its fat-soluble nature. Hemolytic anemia from a variety of causes has been seen in newborns, especially the premature infants, and causes an increase in breakdown of the red blood cells. Allergic reactions to vitamin K3 has also been reported. For recommended daily allowances, again, changes with age. You will need to look these up. For the water-soluble vitamins, vitamin B1, thiamine, deficiency was common early in the 19th century and resulted in the disease beriberi. However, this disease is not commonly seen today, except in special populations such as alcoholics. Physical symptoms of thiamine deficiency include fatigue, GI problems, muscle weakness, atrophy, bradycardia, and heart enlargement. Multiple peripheral nervous system problems such as numbness, tingling, losses of reflexes can occur, and more subtle central nervous system changes such as memory loss, decreased attention span, irritability, confusion, and depression appear as the disease process progresses. Prolonged thiamine deficiency can result in permanent damage to the nervous system. Alcohol abusers are particularly prone to the disease since their diet is often inadequate. Alcohol decreases intestinal absorption of thiamine, and thiamine is required to metabolize alcohol. Wernicke's encephalopathy is a thiamine deficiency disease which is seen in both alcoholics and people with pernicious vomiting. Symptoms can range from mild confusion to coma and death. Toxicity is rare, and side effects are mild because thiamine is water-soluble and excreted readily from the body. For RDA, again, changes with age, and can look this up as well. Vitamin B2, riboflavin, discovered early in the 1900s. Deficiencies does not occur in isolation. It occurs along with multiple nutrient deficiencies. However, symptoms resulting from inadequate B12 intake have been isolated. These include cracks in the corner of the mouth, and inflammation of the oral mucosa accompanied by purple-tinged glossitis, eye irritation, dermatitis, mood changes, depression, and hysteria, as well as growth retardation and malformations. No toxicity symptoms have been reported, and riboflavin does change with age for the RDAs. For the vitamin B3, Niacin deficiencies causes cell destabilization that, if not corrected, results in damage to and destruction of cells throughout the body. This disease is called pellagra, meaning raw skin. Symptoms are most clearly in body systems where cells divide rapidly, such as the skin, GI tract, and nervous system. Initially, the persons report weakness, fatigue, anorexia, and indigestion. As the deficiency progresses, the symptoms include dermatitis, diarrhea, and dementia. The 3 Ds. If uncorrected, the 4th D, death, may occur. Deficiency rarely occurs by itself and is often seen in multiple nutritional deficiency states. A treatment of patients with pellagra with niacin alone usually is not sufficient to completely effective without consideration of other possible B complex deficiencies. Megadoses of niacinic acid overdoses cause skin irritation and flushing, as well as GI irritation, possible liver damage, and multiple enzyme changes. All symptoms are reversible if niacin doses are decreased. The RDA again changes with age. Vitamin B6, pyridoxine, folic acid, vitamin B6, and vitamin B12 work together to play key roles in recycling homocysteine into methionine, one of the 20 or so building blocks for which the body builds new proteins. Without enough folic acid, B6 or B12, this recycling process becomes inefficient and homocysteine levels increase. The vitamin is also used in treatment of neuropathy and as a precursor of serotonin. It works with other B vitamins to help mood swings for women on hormonal contraception. Vitamin B6 works best in combination with vitamin C, magnesium, zinc, and other B vitamins. Because B6 is involved in so many enzymatic reactions, deficiency presents in a wide array of symptoms. No particular disease is associated with this deficiency, but similar symptoms to riboflavin and niacin deficiency are seen. High doses of vitamin B6 have not been shown to be particularly harmful, although nervous system effects such as numbness, clumsiness of hands have been reported. A water-soluble vitamin B6 is rapidly excreted in the urine. Again, RDAs are different for different age groups. Vitamin B12, a deficiency in this can result in lack of intrinsic factor in the gut, which helps to absorb vitamin B12 from foods. Any disruption in the GI architecture, such as surgery or disease, inhibits absorption, and as does the development of antibodies to intrinsic factor, or inheriting a disease that affects intrinsic factor formation or function. The classic symptom of B12 deficiency is pernicious anemia or megaloblastic anemia. Other deficiency problems include peripheral nervous system changes, numbness, tingling, and ataxia, central nervous system changes, moodiness, confusion, agitation, delusion, hallucinations, and eventually psychosis, and GI problems, loss of appetite, nausea, or vomiting. Deficiency often is found in geriatric populations and frequently is related to loss of intrinsic factor. The need for supplementation is increased by increase in metabolic rate, such as hyperthyroidism, by GI tract diseases, and by pregnancy. Because B12 is found in animal fat, vegetarians become deficient unless it's supplemented in their diets. If B12 deficiency is caused by a lack of intrinsic factor, then intrinsic factor must be replaced by injections. Patients with type 2 diabetes taking metformin treatment should increase their dietary intake of vitamin B12. And for toxicity, B12 is stored in the liver in significant quantities. Excretion of excess B12 is rapid, and symptoms of toxicity are not seen. Recommended dosages, again, changes with age as well as pregnancy. For the folic acid, in addition to recycling homocysteine, folate plays a key role in building DNA and is especially important for women. Deficiency is one of the most common deficiencies in humans, with symptoms similar to B12 deficiency. Intake of folic acid may disguise the symptoms of B12 deficiency, so it may be important for a clinician to determine the patient's level of B12 before treating him or her for folate deficiency. Megaloblastic anemia is a worrisome complication. This deficiency is seen in pregnancy and often occurs during the 3rd trimester. If megaloblastic anemia is present before conception, fetal neural tube defects such as spina bifida and anencephaly may result. Intake of folic acid consumption, which also can occur without megaloblastic anemia, can lead to open neural tube defects. Inadequate folic acid intake will be evident in serum as little as 1 month, and red blood cells and liver stores will be depleted in less than 3 months. Deficiencies can result from inadequate intake, defective absorption, and abnormal metabolism. Even though folic acid is water-soluble, symptoms of toxicity have occurred. Most severe among those is permanent nerve damage. Folic acid concentrations are restricted in over-the-counter preparations to guard against this toxicity. Recommended daily allowances changes with age. Men and women should take 400 micrograms per day, and women 800 micrograms per day during pregnancy, as well as 500 micrograms per day during lactation. For biotin, deficiency is rare but can be induced by consuming large quantities of raw egg whites. Compound in the egg white binds with the biotin and inhibits absorption. Symptoms include non-pruritic dermatitis, hypercholesteremia, ECG changes, anemia, anorexia, nausea, fatigue, and muscle pain. Simply cooking the egg white destroys this compound. Young infants can develop a biotin deficiency from poor absorption and can exhibit similar symptoms. Treatment with biotin provides prompt resolution. Toxicity has large doses have not produced any toxic symptoms because of its water-soluble nature. It's easily excreted and when taken in excess. Again, changes with the RDA changes with age. And can be looked up. Vitamin C is another fragile vitamin that is readily destroyed by heat or exposure to air or alkalis. It's most common antioxidant found in vegetables and citrus fruits and is considered important in repairing damage caused by free radicals and in preventing them from becoming cancerous or accelerating the aging process. Vitamin C plays a role in controlling infection. It's also a powerful antioxidant that can neutralize harmful free radicals and helps to make collagen, the tissue needed for healthy bones, teeth, gums, and blood vessels. Although research has not confirmed that vitamin C prevents colds in most people, it does seem to prevent colds in select populations, such as individuals under heavy short-term physical stress. Deficiency in vitamin C is called scurvy. Symptoms are related to the breakdown or lack of repair of collagenous tissue, which causes muscle weakness, bleeding, swelling gums, tooth loss, rough skin, delayed wound healing, anemia, fatigue, and depression. This condition is not widespread in the United States, but is still seen in some populations and should be considered when a person presents with these symptoms. Children are at high risk for permanent damage when vitamin C deficiency persists. Damage to the junctions of the bone and thinning of the jawbone causes loose tooth, spongy gums, and resorption of dentine are among the most disturbing problems seen in children. Toxicity, because vitamin C is water soluble, it's easily excreted, and some mild symptoms of toxicity have been seen. GI disturbances such as diarrhea, nausea, vomiting, stomach cramps, facial flushing, headache, dizziness, and faintness have all been reported. RDA, again, changes with age. 200 to 300 milligrams of vitamin C a day appears to be a good target. However, this does change as new research is uncovered. For the minerals, calcium is the most abundant mineral in the human body, found in the bone. Only 1% of the body's calcium supply is found outside the bony skeleton, but this 1% is crucial or critical for nerve transmission, muscle contraction, and blood clotting, just to name some of the roles. Other minerals such as magnesium, sodium, phosphorus, carbonate, and citrate combine with calcium to form the complete bone matrix. Calcium supplements have been shown to help maintain bone density. Deficiency can occur at any time of life. However, in the United States, it's usually a disease of aging. And some studies have shown an impact on the development of such diseases as hypertension and colon cancer related to deficiencies in calcium. Major condition is osteoporosis from lack of calcium. Toxicity, usually calcium toxicity does not occur despite high oral intake. However, in the presence of other mineral imbalances such as magnesium deficiency, soft tissue calcification can occur. Some disease states cause hypercalcemia and renal stones, but these seem to be related to internal management of calcium sources and not to excess intake. RDA does change for age. Calcium requirements during pregnancy and lactation increase, as well as it increases for those over the age of 51. Chromium is a trace mineral with serum containing only 20 parts per billion. Deficiency include those symptoms of glucose intolerance. They include hypoglycemia and mood swings associated with rapid, large swings in blood glucose levels, especially after carbohydrate-rich meals. High blood pressure, heart disease, stroke, and obesity may all occur over long term with problems associated with diabetes. And almost inevitable consequence of chromium deficiency. Symptoms are reversible when chromium is provided in the diet or supplements. Toxicity can occur. Excessive amounts can reverse the beneficial effects and eventually cause a decrease in insulin activity. Again, as with all the rest of the vitamins and minerals, RDAs is different for different age groups, and you should be able to look this up. Fluoride, now an increasing number of towns and cities add fluoride to their water supply, decreasing the need for supplementation. And the American Academy of Pediatrics has recommended the use of fluoride supplementation for infants and children if the area in which they live do not supplement their water. Deficiency was common until water began to be fluoridated, but the only symptom appeared to be weak dental structures and a marked increase in cavities. Toxicity can be significant and usually results from unusually high doses given for prolonged periods. One-time dose of 2,500 times the RDA can be fatal, but is rarely seen. RDA, again, changes with age. For iodine, trace mineral found in most parts of the body, with 50% in muscle, 7% in bones, 20% in the thyroid gland, 10% in skin, and 30% in the endocrine glands. Goiter is the classic symptom of iodine deficiency and can appear after several months of inadequate iodine intake. Toxicity is usually not a problem for someone with a normal thyroid gland. Recommended daily allowances. Changes with age. For adults, it's usually 150 micrograms per day. Iron in hemoglobin, ferritin, and ferritin. Iron is available as a recycled mineral or is taken in the diet. Once taken in, iron is stored in the liver, spleen, and bone marrow, close to the sources of hemoglobin production. During pregnancy or as a result of chronic blood loss, iron stores can be depleted at a rate of 10 to 40 milligrams per day. However, during pregnancy, the absorption of iron increases to 15% as the body's way of adapting to physiologic anemia of pregnancy. Iron supplementation has been found to provide relief for persons with angiotensin converting enzyme inhibitor, induced dry cough. A deficiency causes the most common form of anemia. Symptoms of anemia demonstrate the importance of oxygen to all living cells. Anemia causes dizziness, headache, drowsiness, fatigue, irritability, heart enlargement, and spoon-shaped meals. Although everyone can be iron deficient, populations at highest relative risk include women of reproductive age, pregnant women, young children, elderly, low-income populations, and any culture or individual whose diet may be low in meat. Toxicity, the body has no effective way to rid excess iron because of physiologic system is designed to recycle this mineral. Iron toxicity is potentially fatal. Populations at relative risk include young children who poison themselves with iron-fortified children's vitamins, or there's mothers' fortified vitamins. Persons with hereditary hemochromatosis who have a genetic condition that results in no excretion of iron, or alcoholics with chronic liver disease or pancreatitis. Recommended daily allowances changes with age and pregnancy, and during pregnancy the dose is increased to 27 milligrams per day, and during lactation to between 9 and 10 milligrams per day. Patients should not take calcium with iron because the two products may bind and interfere with drug absorption. Magnesium, which is considered a major mineral, accounts for only 1.75 ounces in a 130-pound person. Bones contain 60% of the body's magnesium, with 27% found in muscle, and serum containing only 3%. Only about 30% of dietary magnesium is absorbed, and the absorption is dependent on several intestinal factors, as well as the presence or absence of dietary fat and other compounds that bind magnesium. Magnesium is a common ingredient in laxatives and antacids, and you need to be aware of this in patients with renal failure. A deficiency Since magnesium is important in cellular metabolism, moving sodium and potassium across the membranes, magnesium deficiency is most visible in the cardiovascular, neuromuscular, and renal systems. Symptoms of mild magnesium deficiency include mental status changes, confusion, personality changes, lack of coordination, GI tract problems, nausea, vomiting, anorexia, and musculoskeletal problems, weakness, muscle tremors. As deficiencies worsen, more symptoms appear, such as tetany, bizarre muscle movements, dermatologic problems, and cardiovascular changes. Magnesium toxicity is rare because the kidneys are efficient in excreting excessive amounts of the mineral. Toxicity may occur in geriatric persons with renal deficiencies or who use large quantities of milk of magnesia. When toxicity is acute, the symptoms may be dramatic and require immediate treatment. Symptoms include severe nausea and vomiting, extreme muscle weakness, occasionally progressing to paralysis, and difficulty breathing that may eventually lead to coma or death. The recommended daily allowances changes with age, as with the other medications. Manganese is another mineral that is present in only trace amounts and concentrated in specific organs. It's found in measurable amounts only in the pituitary gland, liver, pancreas, kidney, intestinal mucosa, and bones. Little manganese is stored in the body, and total manganese levels does not usually measure more than 20 milligrams at any one time. This mineral is excreted primarily through the bowel in feces and bile, and little manganese is renally cleared. Deficiencies have not been reported in humans because most of the other minerals take over the biochemical roles of manganese. Toxicity is possible because the mineral is not quickly excreted. Symptoms include iron deficiency, anemia. Manganese interferes with the iron absorption, depression, insomnia, impotence, leg cramps, headache, and speech impairment. In significant toxicity states, symptoms can resemble Parkinson's disease or viral encephalitis with flat facial expression, muscle rigidity, and spasms, and delusions or hallucinations. The RDA, again, changes with age. Men require 2.3 milligrams per day, women 1.6. Adults and pregnancy, the dose increases to 2 milligrams per day. Phosphorus is a major mineral, second only to calcium in body requirements. Phosphorus and calcium are linked, that a decrease in one mineral causes a decrease in the other as the kidney attempts to maintain a stable calcium-phosphorus ratio. Deficiency is not common because of the abundance of phosphorus in the diet. Toxicity usually is uncommon because the kidneys closely regulate serum levels. The single largest problem with the result of excess phosphorus intake is an imbalance in the calcium-phosphorus ratio. The RDA changes with age. During pregnancy, it's about 700 milligrams per day. Women, 700 milligrams per day, usually. And unless the woman is between 14 and 18, which it should, the dosage should be 1250 milligrams per day. Potassium is a key cellular constituent involved in cellular metabolism, muscle contraction, and nerve conduction. Most all body stores of this mineral are intracellular, creating a large concentration gradient across cell membranes. Deficiency is relatively easy to develop. Common causes include diuretic therapy, trauma, burns in particular, starvation, bulimia, gastroenteritis, especially nausea, vomiting and diarrhea, and diabetic acidosis. Symptoms of deficiency range from mild muscle weakness, impaired growth, bone fragility, and mental status changes to severe paralysis, decreased heart rate, and death. Toxicity can be occur and be deadly, with symptoms ranging from confusion, fatigue, and intestinal tract changes to irregular or rapid heart rate, dropping blood pressure, and paralysis of legs and arms. Convulsions, coma, and cardiac arrest often occur before death. Toxicity can be caused by excessive potassium supplement intake or by sudden increase in dietary potassium, as when switching to a salt substitute such as a potassium chloride and using it excessively. Other medical conditions such as acute or chronic renal failure, adrenal insufficiency, severe acidosis, respiratory or metabolic, or systemic infection can cause potassium excess. RDA changes with age, 4.7 grams per day, both sexes, including during pregnancy. Doses increased to 5.1 grams per day during lactation. Selenium is a trace mineral that is closely related to sulfur in its behavior. It's found in higher concentrations in the kidney, heart, spleen, and liver, but is present in all body tissues except fat. Mineral helps to protect the body from cancers, including skin cancer caused by sun exposure. It also preserves tissue elasticity and slows down the hardening of tissues associated with oxidation. Dietary sources of this mineral include whole grain cereals, seafood, garlic, and eggs. Deficiency of selenium and vitamin E often look alike, but selective selenium deficiency has been seen in areas of the world where poor selenium levels are in the soil. Cardiomyopathy with resultant heart-related death has been seen, along with increased relative risks of cancer death. Toxicity can occur. Both the kidney and lung excrete selenium, but toxicities have occurred. Individuals exposed to high selenium levels who are working in industrial settings having higher incidence of liver disease and cardiomyopathy. Persons who are exposed more gradually from foods grown in selenium-rich soil experience milder symptoms such as dental decay, hair loss, fatigue, and occasional paralysis. RDA changes with age, 55 micrograms per day for men and women, adults, and during pregnancy the dose is increased to 60 micrograms per day, and during lactation 70 micrograms per day. Sodium is an essential mineral for nerve conduction and cellular function. It accounts for 0.15% of body weight and is found in every cell of the body. Different from potassium, sodium is concentrated primarily in extracellular fluid, again creating a concentration gradient. Deficiencies is rare, and when it occurs, it's strongly associated with abnormalities in water management. Both dehydration and excess water intake causes a sodium imbalance. Dehydration causes direct sodium loss, and water intoxication dilutes normal serum sodium content. Sodium deficiency is seen with diuretic use, starvation, GI tract problems such as vomiting and diarrhea, profuse sweating, and excessive water intake. Symptoms of sodium deficiency include muscle weakness, mental status changes, acidosis, and tissue atrophy. Toxicity can occur and results in excessive water retention. If too much water is retained, edema and adverse cardiovascular effects such as hypertension, dizziness, stupor, and possibly coma are seen. Recommended daily allowances changes with age. For adults 50 to 70 years of age, 1.3 grams per day. Those older than 70, 1.2 grams per day, and 1.5 grams per day during pregnancy and lactation. Maximum of 5 grams per day has been recommended by the dietary guidelines. Finally, sulfur and zinc. Sulfur composes almost 0.25% of the total body weight. Deficiency symptoms are unknown, although it's possible for deficiencies to develop. Toxicities have not been reported, and ingestion of excessive amounts have not shown to be dangerous. There are no recommended daily allowances posted. For zinc, zinc is a trace mineral that is present in only tiny amounts, 2 to 3 grams total. Zinc supplements are frequently ordered to aid in wound healing. Zinc is found in many foods that are a part of a normal diet, including fortified cereals, meat, poultry, and whole grains. Deficiencies can produce widespread changes in skin, hair, growth retardation, anemia, poor wound healing, lethargy, and sterility. Causes of zinc deficiency include poor dietary intake, especially protein, calorie malnutrition, acute or chronic infection, lots of zinc being used up, alcoholism and liver cirrhosis, renal disease, and malignancy. Populations at relative risk for zinc deficiency include children, pregnant women, hospitalized persons, low-income persons, elderly persons, athletes, increased loss through their sweat, and strict vegetarians. Zinc is critical in pregnancy and normal fetal growth and development. Inadequate zinc levels during pregnancy can cause congenital malformations, including changes in skeletal, brain, heart, GI tract, eye, and lung tissues, as well as growth retardation. Toxicity is rare, and high zinc doses are required to produce toxic syndromes. The upper tolerable recommended dose of oral zinc in adults is 40 milligrams per day. Higher levels have been associated with a decrease in copper absorption, resulting in anemia. Intranasal zinc may be associated with asomia, and caution is recommended in its use. Chronic intake of zinc at levels of over 450 milligrams per day can cause sideroblastic anemia. A 10 to 30 gram intake can be lethal in adults. Toxic symptoms may include GI problems such as nausea, vomiting, mental status changes, drowsiness, sluggishness, lightheadedness, and restlessness, as well as muscle coordination problems. Recommended daily allowances changes with age. Men should have 11 milligrams per day. Women should have 8 milligrams per day. As adults, dose increases 11 to 12 milligrams per day during pregnancies and 12 to 13 milligrams per day during lactation.